It's a good day to you all and welcome to yet another edition of our podcast here at Humana People to People. Now, HIV and AIDS has affected Namibia, a country of slightly more than 2.5 million people in various ways. In 2002, the HIV prevalence rate reached a peak of 22% and many efforts were initiated towards fighting the spread of HIV and AIDS. Namibia is one of the 3 countries in Africa that has met its UNIAIDS 1990 targets. DAPP Namibia has and is still supporting the government of Namibia in HIV prevention by covering Namibia's 7 regions from 2009 to date. DAPP Namibia has furthermore implemented total control of the epidemic, TCE, a program that has equipped people to develop a community-based defense, thus empowering them to take control against HIV and AIDS. DAPP Namibia has further implemented total control of the epidemic, TCE, a program that has equipped people to develop a community-based defense, thus empowering them to control HIV and AIDS. To help us know more, we have a special guest from DAPP Namibia in person of Maria Johannes, who is part of the technical cooperation and will be sharing TC experiences with the Ministry of Health and Social Welfare. Here's Elton Chinowaita in conversation with Maria Johannes.
Good day, everybody. Today we invite you to be part of our conversation where we are going to focus on HIV and AIDS. Soon the world is going to mark World AIDS Day, which happens to be on the 1st of December every year. There is focus on the major disease that has affected lives over the years. Many lives were lost. Quite a number of various initiatives were carried out that has responded to make it easier now for HIV and AIDS to become a manageable disease. Humana People to People is an international organization that implements development work. Health is one of the specific thematic areas where it engages various governments. It works also with some of the affected communities, the infected people, who has to be supported, who has to be given enough information, who has actually to be brought into linkages with essential HIV/AIDS services, be it testing, be it treatment. As such, it has 29 members, of which development aid from People to People Namibia is one of the members. DAPP Namibia has been implementing the total control of the epidemic program for the past 15 years. The program has engaged many people into taking control against HIV/AIDS infection for those ones who have been living with HIV and AIDS. They've been also brought into some essential services, which includes initiation into treatment, which has made it possible for a number of people actually to live longer, and for some actually to end up having children who are HIV negative in Namibia. So joining me on the other end is one of the program coordinators who is working with total control of the epidemic in Namibia. And she is going to be part of the conversation today as we focus on how DAPP Namibia, through the total control of the epidemic program, are responding or are fighting HIV and AIDS. So without taking much of your time, I would like our guests to share with us her name, and as she briefly tell us briefly about herself, as well as the past and also her present engagements. Now, if you may take the floor.
Okay, good day, everyone. My name is Maria Johannes. I work for DAPP Namibia with the program, the total control of the epidemic program. And I am currently the division commander for TCE Erongo. And division commander in lay terms could be equated to a regional coordinator. So Erongo is in the coastal line of Namibia, and it's very cold. Yeah. I have joined DAPP in 2012. I've gone through several, I like to call it challenges, because then you grow as you go up. So my first position in DAPP was a monitoring and evaluation officer. And then as years goes, I went through being a programs officer, and then I went to do my diploma in project management in Zimbabwe, and from there I became a programs officer and then a division commander somewhere in another region, and now I'm a division commander in DAPP Erongo. It has been a wonderful journey for me working with DAPP Namibia.
Now, tell us a bit about your first impression in general as a person who grew up in Namibia. I understand you grew up in Namibia. How was the HIV/AIDS state back then?
Well, before I worked for DAPP, I already was working in the HIV/TB world. I was working TB program. And has been a known fact with HIV, at the onset of HIV, really, we've had a lot of deaths that are related to HIV and AIDS. And it has been one of the most damaging of livelihoods and households, where parents would die and children will become parents. And so we've had child-headed households because then the parents have perished because of HIV. And it was devastating. People got scared. There has been a lot of stigma against people who are living with HIV. They've been labeled to have that disease. People took it, if you are infected with HIV, then that means you are on your way to death. So there was a lot of perceptions about being infected with HIV. People didn't believe that if you are infected with HIV, you could live longer. And as time goes, and organizations like DAPP Namibia and others came on board to give awareness to people about HIV infection, prevention, treatment, and what it could, or how important it is for people to understand those facts. Then the communities started to embrace the information, started to use that information for their own benefits. And they started to seek for health services. As health services came closer to the people through organizations like DAPP and others, then people started to take up the services and also get to sort of used, although we'll never get used to being with HIV infection. People accepted that this is with us now and we just need to take care of ourselves. As
you reflect and go back into memory, just building on from what you said, that back then, and then there was so much loss of life. There were many child-headed families that were there. What would you say were the major drivers of the HIV/AIDS infection among the various people in Namibia way back?
I think back then it was lack of awareness, really, and people had no access to information about how do I get infected, what do I do when I'm infected, and that the services were far from people back then. People had to go and seek services, would need transport to go to the bigger facilities to seek for HIV testing. And even when you go for HIV testing, treatment was not offered right away like it does now. So I think that made a bowl of what drove the new infections. People were not aware of their own HIV stages, because if you are not aware, then you are not in a position where you can protect the next person. And if you are also afraid that if I found out that I am infected with HIV, then what? Because then I have to go and go an extra mile to seek for the health service, for example, treatment. And then what did that mean? What did that mean for me as an individual person? What did it mean for me if people knew that I am HIV positive? So lack of information, services were far from people. People had to travel some distances to go and seek for services. We didn't have community-based HIV services back then that came on board around the 2005 and so. So then even when you get tested, what did it mean for you? You were not going to get treatment right away. You go through the other loops that you have to be at this point so that you get started on treatment, because then treatment was not just readily available for everyone who's getting infected. So then there was also a part where people were afraid to be stigmatized. So then it's just fear that I get tested, I test positive, somebody finds out, and then what? So it was all of those contributing factors that were contributing to the new infections. And if people don't have the information, for me, that is the biggest contributing factor towards anything at all. If you are not aware that you need to be at what position, then you will go into that position, because then you are not aware, you don't have the information, you don't know how to protect yourself, or protection is not available. So yeah.
Now, considering all this array of different contributing factors you have alluded to as driving the HIV/AIDS spread in Namibia, what has DAPP Namibia done as part of responding to those gaps, to those challenges, to those issues that were identifiable back then?
DAPP came aboard on the 2005. That's when they started implementing these activities. That was more raising awareness and spreading information for people in communities to know what is HIV, how do I protect myself, how do I prevent the second person from getting tested. If I am tested, where do I go get tested to begin with? What else if I tested? And then going into the process of what support do I have in place for me as a person living with HIV, and also for people that are not infected, what do they do? What support can they give to people who are living with HIV? So then DAPP came on board with just working with the communities together, because then the force came from community. People who were working for DAPP or who were DAPP employees, who we call TCE field officers, came from those communities. They were people who saw the people in the communities every day. They lived with them, they knew them. They were their mothers, they were their parents and uncles and sisters. So people then were aware and they were made aware about the HIV information. And because then people who were the field officers came from the communities themselves. So then DAPP in Namibia did really a lot of contributing towards the Ministry of Health's effort in raising awareness and in bridging that gap between the facility, the health facilities and the community, and working together into providing the services for the people. And while it started as sharing information, basic HIV information, it grew into taking these services from the health facility to the people that are in hard to reach areas, services that the health facility staff members could not take to people because then they were all busy here at the health facility. So then they would, around 2013, 14, that's when we started doing home-based HIV testing, which people thought, oh, what is that? How do you do that outside the health facility? But then it became possible. And then as the program evolved, it now has grown into targeting people that are likely to have been infected with HIV. So as the gap of people who don't know their HIV status grew smaller, then the services are also evolving into becoming targeting of people that we are aware might be infected with HIV. So in one word, DAPP in Namibia grew with the HIV, growing with the HIV epidemic. We are getting smarter, and we are working with the line ministry and the stakeholders into getting smarter on how do we control the epidemic.
I was saying that, so you can say DAPP in Namibia went through a process of improving their approaches to HIV and AIDS as part of adaptation, as part of evolving, such that there is much more effectiveness to respond to the emerging needs or gaps that are coming from the HIV and AIDS.
Yes.
Okay, good.
That's very true.
Now, yeah. I would like us to focus on one of the major programs that DAPP Namibia is implementing, which is the total control of the epidemic. Mm-hmm. It is a big part of what you are working with in Namibia. Tell us a bit about what is total control of the epidemic and what are some of its major activities.
Like you say, total control of the epidemic, aiming to bring the epidemic down to what we can say, this is now something that we can manage. And this project is aiming at contributing to the effort of the government into what we want at the end of the day to have 0 new infections in the country. And then we also want to make sure that at the end of the day, people who are not aware of their HIV status know their HIV status, and people who are HIV infected are being taken care of and they are on treatment, so that then they are retained on treatment to reach viral load suppression, which is at the end of the decreases or eliminate the new infections. So the goal is to reach that 0 new infections in the future. And we have several major activities that we are implementing the total control of the epidemic program. And one of them is HIV testing. And we are doing HIV testing with what we call index contacts testing. So this activity aims to make sure that everyone that is or has been at some point maybe at risk of getting infected with HIV is tested. And do this with working with the people that are tested HIV positive, and we have discussions with them after they've been tested HIV positive and they've been newly diagnosed. We talk to them, and then we find out who are their sexual partners who might have been infected with HIV, who are their biological children, and because then whoever is blood related might be infected with HIV. So then we get consent from them to offer HIV testing to their sexual partners and their biological children who are below the age of 18. In that way, we want to follow the chain if there is any chain there, and we want to follow and find out, is there anyone who could have been infected around this index person? And from then we make sure that everyone, once they get tested, they either get the prevention services, which is what we call PrEP, the prophylaxis that is given to HIV negative sexual partners who have HIV positive sexual partners, so that they are prevented from getting infected with HIV. Or then we refer them to BMMC, which is the voluntary male medical circumcision for men. All of these services are just aiming at preventing that either sexual contact or a biological child from getting infected with HIV. And then the ones that will test HIV positive, then we refer them for treatment, so that then they are put on treatment, and we enroll them on our trios. And we'll talk about the trio a little bit later, but the trio is, as it sounds, 3 people in a small group that are supporting the person. We have a positive client, and then we have 2 treatment supporters that are supporting this positive client, with reminding them to go for their follow-up, with reminding them to take their medication. And we just want everyone who is tested HIV positive to be retained on treatment, so that at the end of the day, they are virally suppressed. And for the ones that are testing positive, because in Namibia, we are implementing what we call test and treat. If you test an HIV, a client, and they test HIV positive, the right thing to do, or the mandate, is that you treat them right away. So what the TCE officers will do is they will escort this client to the health facility, so that we make sure that the client is supported, And the client is also the facilitation of the process of getting initiated on ARC treatment has happened, and then the client does not have to do that or go through that process alone. So that's one of our key activities. Our second key activity with the TCE program is now we have clients that are on treatment, and there are many contributing factors towards as to whether I, as an individual who is on treatment, stick to my follow-ups, and sometimes the clients can or end up interrupting their treatment. They will miss their appointments to come and pick up their pills, or they will miss their appointment to come for their clinical visit. So if in any chance that happens, then we are working with the facilities that those clients are listed, and then we trace them via phone call. And if we cannot get them via phone call, then we trace them physically at their physical address, because we want everyone to be treatment and do not want to miss any. If anyone has missed their appointment, then we trace them back and then facilitate or have discussions with them so that they are re-engaged or they are restarted on treatment. And then the next activity would be then a trio for all of the clients that are having adherence challenges. They are missing their appointments, or they are having their viral load is not suppressing, it's taking longer to suppress, or it's high for one reason or the other. Then the discussion is held that then there is support in place. There's a support system at home, as much as when they will have a support system at the facilities. So we go into a discussion with that client that they disclose to at least 2 people that would support them throughout their treatment, reminding them, like I said before, to go for their follow-up, or reminding them it's time to take your medication. So we discuss with the client and find out what are the challenges that you have. Why are you not coming for your follow-up? And together with the client, try to find ways to solve the challenge. And it's more cases that then we will refer that client to other line ministries or other stakeholders that are working in the HIV and TB field, so that that client gets full support. Some clients have social challenges, so we refer them to social workers, so that as specialists in that field, then they will discuss with the client and try and solve that challenge. And then we are also having one of our, and this is really close to my heart, is our mother-baby follow-up, where we work with the HIV positive mothers that are either pregnant or they have babies. We have discussions with them at household level to make sure that they are aware of how they can take care of themselves, mothers, and also how to take care of babies, so that at 18 months, when we test, as it is required by the Ministry of Health, we test that at 18 months, we want that baby to be HIV negative. So the prevention of mother-to-child transmission is one important activity that DAPP is implementing, of course, in collaboration with the Ministry of Health. So all the mothers that are pregnant, when they come for ANC, they get tested for HIV. They get to be referred to a field officer, and then a field officer enroll them in the mother-baby follow-up PMTCP activity. And if pregnant, then we keep in discussion with the mother throughout her pregnancy. We discussed follow-up dates, and towards delivery, we discussed about feeding options that are in place, what are the safe feeding options in place, what could the mother do for the baby. And once the baby is born, then the PMTCT activity grows into another baby pay follow-up, because there is a mother now and there is a baby now. So and then the field officer continues working with the mother and say, this is when the baby is supposed to go for their HIV testing, so that we just know that the baby is safe. Please continue taking your medication so that they protect the baby. And it goes, they have 4 intervals of testing. And at 18, that's when we graduate our kids, our babies, off of the mother baby. And 18 months, the baby is tested. And then we find out we have done a great job. Our baby is HIV negative, or unfortunately, or the baby is infected. But the sole aim for the mother-baby follow-up is to make sure that we have 0 new infections among babies that are born by HIV positive mothers. And then we have one of the sort of new activities that started like a year ago, where the DAPP Namibia, where collaboration with the Ministry of Health and Social Services to share experiences from the communities, from working with the people, with the health care workers that are based in the facilities, especially in health facilities where there are no TCE field officers, so that we will share what we know, what worked well, what we tried and couldn't work. And then with that experience, we tailor it according to that, to the people who are living in the catchment area of that health facility. And we call that the technical collaboration and sharing of best practices with the Ministry of Health, which is amazing. At the end of the day, we want sustainable activities that could be sustained. We all know that the TCE program is funded by funding organization, funded by CDC. And unfortunately, we know that it's not going to be forever. So at the end of the day, we want these activities to still be active, even when TCE is no longer the TCE that is being implemented currently. So shortly, those are our sort of major activities that we are doing. Apart from, of course, prevention, we are working with the adolescent young girls and men in making sure that they are aware how to prevent HIV transmission. We are referring the young men to male circumcision, and we are also doing TB screening, because we want to know that our people who are living with HIV are not at risk of getting TB. That's where the TB prevention therapy come in. We have the new one that is called 3HP. You get your 1 tablet once per week for 3 months if you are living with HIV, so that then you are protected from getting TB, and that goes for also our TB contacts or babies that are under 5 years, and they are also TB contacts. So yeah, it's a big project. We can talk about it forever, and I can go on and on, but those are the activities that I just want to highlight.
You have brought in quite an interesting input, which is the technical collaboration you are having as DAPP Namibia, together with the Ministry of Health and Social Services of the government of Namibia, where you are working together in terms of sharing of experiences is what you have alluded to. Now, I would like you to shed some light on what exactly are you doing? How are you cooperating? If you can describe to somebody who is not even knowing of how this cooperation is going about. What exactly is it? How did it come about?
Okay, thank you. Just a little bit of background. TCE, the TCE program has been implemented in 7 regions in the northern part of Namibia, and central. So that's where most of our population is. And that has been since 2005. And towards 2017, then there was need to say, how do we replicate the good success and from the contribution that the TCE program has made in those 7 regions. And then discussions were held, and then we had an agreement that, okay, so what will happen, we will take the experienced staff, TCE staff members, and then we would visit the other 6 regions in the south part of the country where the TCE program has not been present. And using the experiences from how well we worked with the ministry in those, let's call them old regions, just for reference. In those 7 old regions, then we go and share that with the new 6 regions, the remaining 6 regions. Namibia has 13 regions, and TCE has been implemented in the first 7, which I'm referring to as old, with the Zambezi, the 2 Kavango East, Kavango West, Ohangwena, Onana, Omusati, and Commerce region. So then with that, then because this is, for years we have acquired this experience with the ministry in those 7 regions. So the plan was that the TCE experienced staff members and the Ministry of Health experienced staff members who have worked with the TCE field officers, TCE supervisors, then we'll go to the new regions, which is Erongo, Unene, Umaheke, Karas, and Hardap, and then share, and Ocho Danjupa, and then share, this is what we have learned. When we wanted to do index contacts testing, how we have done it, and it worked well. And when we wanted to trace our clients that have missed appointments, this is how we have done it, and it worked very well. So let's see if it will work here. Let's see if it will work for this population, because of course, it's not a one size fits all. The Namibia is very diverse. People live very different. You would come from one region to the other, and it's like you have crossed borders. They have different ways of living, they have different cultures, and they have different languages. So we had to look at what we have learned and come and share it with the staff members that have not worked with the TCE program or in collaboration and have not interacted with the TCE program before, and say, is this something that can work for this population? Is this something that we replicate so that we get the same results or closer to what we got in the other regions? So that's how the technical collaboration and sharing of best practices came on board. Unfortunately, somewhere when we just started, we did our first round, we came to the new regions, we shared some of the experiences, then COVID-19 happened. So we were restricted. We couldn't travel in bigger groups. So then we said, okay, because we cannot travel in bigger groups, let's say 4 TCE experienced staff members. Let's go to the new regions and share, and let's not take the whole ministry cadre with us. Because then we planned, then we come to the new regions, we share what we know, and then the new region choose some of the staff members to go to those regions that have implemented the TCE project, and then we go and observe and learn. How is it done? How do people work with the field officers? How do you even refer clients from the facility to the field officer? How does a field officer go in the community areas? How do you do home entry? How do you approach people? How do you go and look for Elton in a village without sort of disclosing that Elton links out because they missed their appointments, for example? So then we started that just here in the regions, and really in what we classify as hotspot towns, where there was high numbers of new cases, there is high numbers of treatment interaction, and because there was a community activity component, then it was not so straightforward. How do we make sure that those rates are decreased? And then we would make rounds to the health facilities, share the best experiences over the phone. We communicate to one another. I have this client, I don't know how to deal with this client. This is what is going on with client. How would you deal with this client? And then we share information back and forth like that. And currently, it's a good practice. We do meetings over the phone. We meet together with the health assistants, one of the cadres at the facilities that are working more with the HIV activity, and share our data and say, okay, this is what we are getting from, or this is what the data is telling us. We are improving, or we need to still do more because we are still having people that are interrupting treatment. What could be the cause? Are these really people who have interrupted treatment? Or we have new cases, but these clients are not telling us who they might have put at risk. How do we deal with that? And then just set a platform where we can improve. So yeah, that's what it is all about in briefly in normal way, if I can say that.
Thank you for such kind of a detailed account that gives background to how this program is all about. But then somebody might be asking, you do a lot of sharing of the experiences. Do you do it as in the form of, what methods can you allude to that is this how you do? Is it community-based, or it follows the structural ways? Maybe you start from the region and then you go to the district and then you go into the community structures. How do you approach the various of the sharing of the experiences, the technical collaboration part of it? Because TCE, as you have said earlier on, is more of responding to the issues to do with the raising more of the awareness about HIV and AIDS through community mobilization, which is its strength. That's how it ends up responding to making people access HIV/AIDS service, be it testing, treatment, or building the supportive care structures, helping those who are to access, who are already enrolled on treatment. How do you do the methods part of this sharing of the experiences?
So the how is, like I said, the experienced TCE staff members who were division commanders, some division commanders, some field officers that were very much experienced in how to do or how to carry out community activities, would meet with the health assistant. A health assistant is more like a community health worker who is only based at the health facility and is employed by the government. And then we have nurses. So we will come to, it's not at regional level, it's not at district level, it's at health facility level. Although we have introductions to say this is what we aim to do at the district and regional level, the activity itself is being carried out at the health facility level.
So
where
it's
we
something
sit
like
down. It's more
clinic-based or hospital-based. Okay.
Hello?
I'm saying that, is it something that is clinic-based or hospital-based?
Yes, it's clinical, it's clinic-based. So in other regions, we have field officers that are based at the health facility. This is what they do. They talk to they work with health assistants to identify clients that are tested HIV positive, or clients that have adherence issues, or clients that are interrupting treatment, and then they will work with those clients together to look for them and give them the services that they need. And when that service is needed at community level, then the health assistant will then give these names to the field officer and say, Elton wants testing at home. We need to look for Elton because we called Elton and Elton is back. I'm just referencing. And then the field officers go and look at that individual and give service that need. Or they will go and train that individual and bring them back to the facilities so they can continue getting care. Now, when we share that, there is no field officer at this facility where we are sharing the experiences and what are those practices that are best. So then the health workers at health facilities will take up and say, okay, so we don't have a field officer, but we can take out time and go and do this community level, then it's possible, it can be done. So those are one of the outcomes that came out of sharing the experiences, and the health workers realized, okay, so there's no limit in going to look for my clients that have interrupt treatment, community level. Oh, okay, that's a good idea because we have struggling to find this person and we couldn't find them, so we will go and look for them. Okay, so those clients that prefer that their sexual partners get tested at community, we can go and do it at community level. So that's how it's done. So it's clinical based, it's clinic based, and then with that, then the health workers at the facility then will use that experience and we can go this extra mile to give the service for people.
Now, despite the challenge of now being affected by COVID-19 pandemic, which coincided also with the implementation of this program you are implementing together with the Minister of Health and Social Services in Namibia, what can you say are some of the immediate impacts which you can say has arisen as a result of this technical collaboration and sharing of experiences?
although the activity has not been implemented over a long period to see a clear impact yet, we have noted, or there has been immediate outcomes that are a result of this activity. For example, in Namibia, the health assistants who are at the same level as community health workers that are based at the clinics were not doing or going to an extent of going to the community and try to look for clients that are have missed their appointment, for example, or and take the HIV testing services. That's not something that they used to do. But now, in these health facilities where we have done the technical collaboration, we have now health assistants that are having schedules to say, Monday I'm at the clinic, Tuesday I'm at the clinic, but Thursdays I'm going to the community and doing my community tracing and going to do my community index partner testing, because then I have these clients that need that service. Or I'm going to visit this mother because then she has not brought her baby for the test that is due. Or I'm going to see how she's doing because last time she visited the facility, we discussed about feeding options, and she wanted me to go and, you know, continue sharing some of the ideas on how she can take care of her baby or how she can continue feeding. So, and now we have, the TCE program has what we call a troop meeting. And in Namibia, it's done bi-weekly. Every Friday, we come together, we look at our data, we say, what does the data show? What is it telling us? And how can we learn from these stories that these numbers are telling us? So now we have health facilities that are taking time to say, okay, so we sit and don't wait for the month. We are not waiting for the quarter. We are not waiting for the district to collect the data and come and tell us this is what your data is telling you. We are not waiting for the region to say, we looked at your data and this is what it said. We are taking off time. Every second week, we sit together, we look at the numbers and say, what are the numbers telling us? Where are we not doing well? Are we recording everything that we are doing at the health facility? And not that they were not doing it, but through talking to people who are from a different angle of things, with a fresh eye to look at what you are doing, you get to learn something out of that and say, oh, okay, this is something we traditionally did not do, and it's awesome. We can take that and use it for our own benefit. We also have, for example, for the region where I'm working, we have now, it's totally up to the patient or up to the client who's on ART treatment to disclose to someone, and that someone become their treatment supporter. Whether, even if it was not something that a health assistant will go out of their way to say, Maria, please, I need you to do this. I need you to disclose so that you can have some support at home. But when we shared the information about the trio and what are the benefits of being in a trio for clients, then we have health facilities that are now sitting down and taking a discussion with a client and say, if you disclose, you would have support at home. And it would be good, you at least have one more person that would be able to support you. So you have two people. If this one travels, then you still have someone that can, if you are at a point where you cannot come and get your medication, they can come and pick it for you. that's one of the benefits. Or if you forget that your follow-up is when, there are 2 more people that knows that your follow-up date is when, and then they remind you, Maria, please go and you remember that your follow-up is coming up when. And also one of the activities that I've not mentioned is we in Namibia, we have an activity that is called community adherence groups, where clients that are on treatment, they are stable, they are virally suppressed, they've been on treatment for a year, they organize themselves in the group of minimum 5, maximum 12, and they organize themselves that one of them, if they need to come and pick their tablets, one of them comes and pick tablets for the whole group. So this is one way of saving transport fare for, instead of all the 12 people going in a taxi and going to get a medication from the clinic, it's only one person, which we could, the taxi fare in Namibia is $12. So if it's 12 people in that group, everyone contributes a $1 and $1 Namibian, and then that one person will go and pick treatment for the whole group. And in a way, these are stable clients, these are adherent clients. They have a bigger support system among them. They can choose to do gardening together, they can choose to come up with an income generating activity together. Another benefit, then it decongests the health facilities. Instead of the nurse seeing 12 people queuing up, then they are only seeing one client who's sitting there with 12 health passports, which also is, that then the facility is not too much, and it also works very well with COVID-19 because then the facilities are not getting crowded. So those are some of the experiences that we have shared with the healthcare workers at the health facility, and we have now started establishing those community adherence groups so that people who are stable don't need to the every day or every month or every time they need to pick up their pill pickup. Then they have one representative who goes pick the medication for the whole group, come back to the community, just meet at an assembly point, and then they distribute their medication to one another. And while they're in that group, then a field officer acts as a facilitator, that then the health passports are brought in the morning, the representative has gone to the facility, the representative is back, all medication are distributed to everyone, everyone has their medication. Or when we are meeting, we have done an assessment where we say we are doing TB, the 5-question TB screening, just so that we make sure that while these clients are not going to the health facility, they are being taken care of as is they are attending their appointments at the health facility. So those are some of the immediate outcomes that have come out of the technical collaboration and sharing of best practices with the Ministry of Health.
That is quite exemplary, and it sounds quite an interesting program you are implementing. Now, I would like to come to you again because you have brought in the aspect of the community adherence groups, which contributes to create some supporting measures to ensure that there is reduction, if completely no defaulting for the people who are taking HIV treatment drugs. When you compare the situation before the community adherence groups were set up and now they've been running, what is the change that you can notice, or that you have been noticing in terms of the numbers of people who have been defaulting and now who are defaulting? What is the difference?
Well, the community adherence group activity works with the clients that are totally adherent, clients who are taking their adherence very well, clients who are virally suppressed, and not clients who are missing appointments or they are defaulting. So it doesn't have, the community adherence doesn't necessarily have an impact on the defaulting rate or defaulter rate, but it has an impact on the support, on the acceptance, on the disclosure, and it also sort of influence clients to be adherents so that they can join those groups, because everyone wants a special treatment. If I don't have to go to their facility every 3 months, I would take that, because then they only have to go once a year when they have to go see their doctor or when they have to do their blood workup. However, your question to say, does this have any bearing on the defaulters? That is, there is no results that I would tell you right now that the community adherence group activity has a bearing on the defaulter rate, no.
So how has it now contributed to achieving viral suppression? Because it is one of the 3 targets for the units 90, 90, 90, which is phased out. Now we have gone into the units 95, 95, 95. A strategy to end AIDS by 2030.
Yeah, the 90, 90, 90 UNH targets still stands for the world. But however, for Namibia, because we have reached our first 90, our second 90, our third 90, then Namibia has shifted these targets to 95, 95, because you can sort of target to reach what you have achieved already. So this is just for Namibia. The activities that I have talked about, index partner testing, the targeting, case finding activity, is one of the activities that contributes to the first 90 of knowing, for people to know their HIV status. The escorting of those ones that have tested HIV positive, the test and treat, contributes to the second 90. And then the retention activities now, which community adherence is sort of under that umbrella, now contributes to the third 90, which is viral suppression, because these clients are already suppressed. But the aim for these clients or for this activity is to make sure that it stays that way. And this is that we make sure that, okay, clients do not have to go out all of their way, interrupting their normal lives to come and sit in queues at the health facilities when they do not have to. So because then services are accessible, services are easily accessible. For these clients who are in community adherence groups, they don't even have to move to get this service. They wait for one of them to come bring the service to them. Then it maintains the virally suppression tar to say, if I don't have to go to the facility, all I have to do is to take my medication.
I would like you to if you may share with us, for over the years, since TC started to be implemented in 2005 until now, in the 7 regions that it has been present, and I guess probably maybe now it is still running. What are some of the notable outcomes or the impacts which you can say TCE has helped to achieve in working together with the community and together in cooperation with the government of Namibia?
Yeah. I'm going to give you a picture. I'm going to draw you a picture of how you would look at TCE program from then to now, to where it is now.
Good.
Just with one sentence. TCE started with the 7 regions in 2005, and for almost 10 years we've been in that area. So we have been working in those areas. But throughout those years, there has been a climb in the ladder of how the program has changed into specifically working with what is needed for the country. And the ministry has really embraced the TCE force into welcoming them and working together with them in taking the activities to the people. So we worked in the 7 regions for the longest time, and now we work in the 13 regions in the country. So that on its own has an indication on how the TCE program has contributed towards the efforts of the government, to an extent that then the government has agreed that, yes, of course, we would like them to be in the rest of the 6 regions, because they would make a big contribution, or they would make some contribution towards having the same services that are in the other seven regions, and having to work the ministry's card in those regions to bring the change. There has been many that have been attached to TCE program, lives that have been changed by the TCE program. But I would like to say the fact that we get funds to go to the rest of the country's region, the fact that the government has agreed to say, yeah, we will continue to work with the TCE program in the rest of the country, says a lot about what our contribution is in Namibia.
Good. Now, earlier on, you mentioned that the prevention of mother-to-child transmission, which is an intervention area TCE in Namibia works with. You have said that it is close to your heart. That means you have actual personal affection to it. When you assess some of the notable outcomes that are driving towards an AIDS-free generation, what have you observed as impacting the community in terms of the results that are coming from this specific intervention?
I would want to say one thing. The mother-baby PMTC program, yes, I love it, because then that means we take care of the people that will be here tomorrow, today, and make sure that whenever we are not here, the ones that are here now and are doing this work now, whenever we are not here, then we know that we have a HIV-free individual, and we have to that. I want to give it in 2017 in Mbezi, we've had one that we had, and this is really emotional. We had babies that are born by HIV positive mothers, and all of them were HIV negative by 18 months. And you look at that and you're like, okay, this is working. We are doing something right here, and our efforts are not in vain. And it's big. This is about it's about, not about we worked with 5 and 5 are negative. Even if it's one person, one baby, for me, it says a lot about that one life, that one baby that is HIV negative and to be HIV negative, and they will grow up into a person that can make their own decision. And I have not been infected by my own mother. So people's lives and just seeing how appreciative that the mothers you work with, I would say, oh, the relief of when the mother tests, brings their baby test, and then they are told, oh no, the baby is HIV negative. The appreciation that comes with that. It says so much. And Namibia is really doing well with this program, and we would want to continue making a contribution towards that as a project, as an organization.
That is quite touching, especially when you see that the life that could have been born HIV positive, actually what was expected from all the efforts directed toward it has reversed what was going to be obvious. Sure enough, it is a cause for very big, wild celebration. Thank you very much for being a part of a program that is actually saving lives and contributing to creating an AIDS-free generation. On the 1st of December, it is going to be World AIDS Day. And the theme for 2021, it is End Inequalities, End AIDS, End Pandemics. What are your thoughts about this theme?
I would say get tested, know your status, and if you have tested HIV positive, get treatment, continue taking your treatment for the sake of yourself and for the sake of everyone else, and for the sake of stopping the spread of HIV, and for the sake of someone who's going to be here tomorrow, and for the sake of the country. And we equality, we are having a long way to go. And it's up to all of us to create inclusion platform where everyone is included in making the decision that is correct for their own health, and no one is excluded at all. And if we would want to say, this is what we work towards, this is what we want to see in terms of sustainable development, there has to be equal access, equal rights, equal everything for everyone in a country. And while Namibia has worked so much towards ending the epidemic, and we put up very good measures to end pandemics, we still have to do a lot, as just make sure we might have reached 90 in terms of HIV. We might have reached our first 90 UNAIDS target. We might have reached our second 90 UNAIDS target. We might have reached our third. But epidemic control has to do with the sustainable control of the infection. And we want to see a decrease in HIV-related deaths. We want to see a decrease in new infections, so that then no one is negatively affected or impacted by the fact that they might be living with HIV, or they are living with people or around people that are infected with HIV. So that's my thought.
Thank you very much, Maria Johannes, for being part of our guest today, where we have been focusing on what DAPP Namibia, through the Total Control of the Epidemic TCE program, have been doing since 2005 to date. You have also assisted us to understand better on the new program, which is about the technical collaboration and sharing of experiences gained over the years by TCE, which has been now being given also to the government of Namibia, specifically through the Ministry of Health and Social Services, such that other regions, the 6 regions where TCE has never been to, they can also utilize the vast experiences which has also contributed to making the difference in the other 7 regions of Namibia, such that there is more effort towards going towards saving lives. There is more possibilities of also reducing defaulting. There is more support going towards identifying the yet to be found people who are HIV positive, but they are still hanging around there, not knowing that they are carrying the virus. They still need to be enrolled onto treatment and be part of the whole process to achieve viral suppression. I would like to take this opportunity to thank you very much and wish you all the best in your efforts. I can understand you are quite a very, very busy person who is working with very much needed programs which all about saving lives. Thank you very much from myself, Elton Chinowaita. Until we meet again, have a good day.